So I'm here to review the TCCC proposed change 21-02 by Andy Fisher. I'm a few months behind in getting this posted to social media. This was published back in May in the Journal of Special Operations Medicine. I don't have a particularly good excuse, but here it is. So in this proposed update, he specifically sought to address the following questions. Number one, what additional analgesic options are appropriate for combat casualties? Two, what is the initial dose of ketamine we should be using? Number three, what sedation regimen is optimal for combat casualties? So here's kind of a brief summary of the changes. I would recommend you read the paper in full for the proposed changes, as there's quite a bit of detail and background information as to why these changes are being proposed, but I'm going to give you the very brief overview here. So non-medical first responders and combat lifesavers should be able to provide analgesia in the battlefield with option one, mild to moderate pain. They should be able to use the combat wound medication pack that is available through our logistics chain. For Tier 3 and Tier 4 medical personnel, they may administer oral transmucosal fentanyl citrate, also known as the fentanyl lollipops, 800 micrograms, and then they can repeat this again in 15 minutes if the pain is uncontrolled with the first dose and the casualty is not at risk for hemorrhagic shock or respiratory distress. Tier 4 medical personnel only administer fentanyl 50 micrograms IV, and you may repeat this every 30 minutes as needed for pain control. Or they may administer 100 micrograms of fentanyl intranasal and repeat that every 30 minutes as needed until pain control is achieved. If the patient is at risk for hemorrhagic shock or respiratory distress, they do recommend using ketamine. The recommended starting dose is 20 to 30 milligrams slow IV or IO push, and you may repeat that every 20 minutes as needed. The dose may be increased to 30 to 50 milligrams for casualties over 90 kilograms. The recommended starting intramuscular or intranasal doses of 50 to 100 milligrams may be repeated every 20 to 30 minutes. They do recommend, if you're going to give the intranasal ketamine, recommend the use of the 100 milligrams per milliliter concentration, so that it's adequately concentrated before you squirt it up your nose. They do specifically state that TBI or eye injury does not preclude the use of ketamine, though it is recommended using it with caution with the dosing, as it may alter your ability to get a good neurological exam, especially if you need serial neuro exams while you're sitting on a casualty. They also posed a reminder that benzodiazepines are not pain medications and should not be routinely administered for analgesia. Benzodiazepine should only be administered during procedural sedation with ketamine when an emergency reaction occurs, and this should not be done prophylactically. And then further emphasizing the need to take caution with risks associated with potential polypharmacy. Again, you can always message me for the full paper, and I've also tagged the lead author in this post, so you can always hit him up with questions as well.